has faced some resistance from private hospitals who see the high uptake in NHIF as a threat to their revenues. Also, this new bill targets the youth who comprise 2/3 of the population. However, it does not stipulate how they shall remit monthly contributions to NHIF after the mandatory registration. At the moment, those in the informal sector have the option of contributing 500 shillings per month. Bridget Ghana, NTV.
My colleague Bridget Ghana, of course, with that story from a month ago. That was on the 28th of May during the National Prayer Day, when President Uhuru Kenyatta, of course, called upon Parliament and the Senate to hasten the passing of the Nhf Amendment Bill of 2021. Let's get you started with that conversation now. We are talking about health insurance in Kenya. The number of people who have medical insurance covers in Kenya today is still very much low, or at least not at the best level that it should be. We want to talk about what that means for the country and what can be done to bring more people and get more Kenyans covered, of course, with medical insurance, because 11 million people in Africa are actually pushed into poverty every year because they have to pay for healthcare directly from the pocket. Let me introduce my guests this morning. I'll start with those joining us virtually this morning. Mr. Kalai Musei is the Chief Manager at the Technical Department of the Insurance Regulatory Authority. Good morning, Kalai, and welcome to the show.
Good morning, viewers. Good morning, Victor.
All right. And also joining us this morning is Gilbert Osoro, is the Manager of Universal Health Schemes. That's at the National Hospital Insurance Fund, NHIF. Good morning, Gilbert, and welcome to the show.
Morning, Victor, and morning, viewers watching us this morning.
All right, and joining me in studio this morning, Dr. Timothy Olwenyi is the Secretary General of the Kenya Association of Private Hospitals. Good morning, Dr. and welcome to the show.
Good morning, Victor. Thank you for inviting me.
All right, and also, of course, this morning, Nixon Shigoli is the Managing Director of AAR Insurance in Kenya. Good morning and welcome to the show.
Morning, Victor, and morning, our viewers.
All right, gentlemen, let's just start with this one. Now, this is a statistic that we picked from the Principal Secretary of the Ministry of Health, that is Susan Mochache, must be last year, and she said, the other year, and she said four out of 5 Kenyans have no access to medical insurance in 2021. Let me just get your reactions and start with you, Nixon, to that.
Thank you very much. Yes, 4 out of 5 Kenyans, that is 80%, may not have access to medical insurance. And this is because of various factors, some on the demand side. Demand meaning the insurance side that generates products for the population to consume, is not being able to align to the income patterns of the population. So you'll find if insurance is consumed monthly or consumed annually, and the patterns do not rhyme with the generation of income for the most population, then they will not be able to afford to buy the medical insurance. On the supply side, that's on the supply side, sorry. On the demand side is the customer themselves. Insurance, private insurers have tried to develop products that would attract majority of the population, but you'll find there is no much uptake. And you remember insurance, you pay smaller premiums, many of you, so that you take care of bigger bigger cases, bigger medical cases for few of you.
So the secret is in the numbers.
The secret is in the numbers. So if you create a product and only a few people purchase, then it becomes a problem.
And we'll come back to how that, of course, impacts the bottom line for insurance companies in the country. But just, Dr. briefly, this should really concern all of us.
Yes, I agree it should. You see, when you're talking about medical insurance, you're talking about insuring against an unforeseen eventuality. That is very difficult for people to do, especially in an environment where people are struggling economically. You're going to take care of your day-to-day needs as opposed to paying for an unforeseen event. Secondly, insurance is also about a promise, and it's about trust. And there might be something for the insurance industry to look into in terms of why is it that people are not taking up the product, even those who can afford to pay. Could it be that we have not delivered on the promise, or that perception is there? So I think those are the reasons why we don't have health insurance. It's mainly an economic issue. It's a perception issue, and people don't necessarily see the need. But it's unfortunate because it's definitely something that we all need, and even the private sector, we strongly believe that we should try and discourage as much as possible people paying for healthcare at the point of service. Let it be that at the point of service you just get service and leave, but the payment is done in advance, So we want to increase the uptake of health insurance.
And I'm definitely very much interested in the issue of the insurers delivering on the promise and how it affects, of course, the uptake. But let me bring in Kalai Musa, is the Chief Manager of the Technical Department of the IRA. Kalai, this should really concern all of us. I don't know if this is a reflection of the entire insurance industry, which we've been talking about. Again, penetration is still very low.
Thank you, Victor. Yeah, I agree. It's actually, I'm being concerned, actually a big one, to say 80% of the population does not have access to medical insurance is really not good enough. But I want to agree with my colleagues that it reflects on the way our insurance status in the country is. Because if we look at why don't we have medical insurance for everybody, you will note that most of the people who have medical coverage are actually probably those in formal employment. Actually, if you look at the figures, the growth in medical insurance, especially the private one, it's very recent. And you find most of those who are covered are actually those who are given that as a benefit by their employers.
That means it's not voluntary.
That's what it means. So what happens to those in the informal sector, those who are not in employment and who are the majority? They're actually not covered. And that's where the issue is.
Okay. Thank you. Let me just come back to you on that, because earlier on, and I am sure there are products nowadays which target people in the informal sector, but in the past, the problem used to be that you guys actually target people with, you know, a constant salary every month.
Thank you for the question. Yes and no. You know, insurance is usually relies on a lot of data, a lot of historical data, and remember, insurers sell a promise, but the person delivering the promise is not within the space of the insurer. So you rely on the medical service providers to offer the service. Now, if insurers don't have consistency in the way billing can be done for all the medical insurance and medical cases, then it is difficult to design a product that suits everybody and all the people in informal.
But we can design different products.
So there's been a trial to design different products. Some of them have failed because of lack of proper demand for them. And in my view, it's the way the health sector is, you know, there is no regulation around there. So the billing is not systematic. So insurers have to use the information that is there. You'll find, yes, the products will come up. The pricing will be much on the higher side. So most of the informal sector will not afford. And therefore, keeping us where we are. The growth will always be small. We are just around 45 billion collected in medical insurance. We are just about 1 million people with private insurance. Just about 1 million. All of us, health insurers, we are around 23. We insure only 1 million, and we fight for only that 1 million. There are no new people coming into that cake to expand, so that when we get more numbers, the price can come down and more people can afford now to buy that product.
Okay. But at this 1 million, do you think you're exhausting your capacity? Where is the problem exactly? We're talking about 25 million Kenyans being adults, which means they require insurance.
I do not think we are exhaust the capacity to tap into more people, especially the mass market, and what we have called informal sector. But the design of those products will require a lot of investment also in technology, because you have to allow them to buy when they have income, and when they do not have, you have to allow them to continue and then buy when they generate more income. And that particular environment is very difficult for insurance planning and be able to generate more of such products, because again, then we will go to the regulation side. There is the risk-based supervision. So there are certain standards you have to meet. So if you create products, you have to think through those standards, the supervision aspect of it, because we want the insurance companies to be sustainable, not to offer products that after 2 days they close the doors. And then the issue of trust now comes in, because then you have to keep the trust by keeping your doors open and paying for the bills.
Let me bring in Gilbert here, because Gilbert, if you look at the figures for NHIF, and this was from the last quarter, I think 10.46 households or people had enrolled with the NHF, which is a decent figure considering that there are 25 million adults in Kenya. But the problem comes in where only 51% of them are active and about 30% is voluntary.
Thank you, Victor. I want to start by, first of all, thanking NTV and the panelists who joined us today to discuss the Insurance Awareness Day.
Okay. Indeed,
the government has implemented a lot of reforms to ensure the uptake of insurance is part, but what has happened, uptake remains very low, as you've indicated. Mm-hmm. It is estimated that 5% of Kenyans slide into poverty every year owing to out-of-pocket expenditure on healthcare whenever care is needed. But at NHF, we are saying we have our flagship, which is the NHF Supercover, which is Kenya's largest reliable, accessible, and affordable medical health insurance cover that enables you and your family to access unparalleled benefit packages. One of the things that I tell Kenyans is that the Bible tells us that our people perish because of lack of sufficient knowledge. Mm-hmm. And indeed, some Kenyans do not join insurance, not that they cannot afford, because at NHF, we are talking of the NHF Supercover, where the premiums are low as 17 shillings per day or 500 shillings per month. Due to ignorance, many of them have not procured insurance cover, and you find cases of what we call adverse selection in insurance, whereby people join at the point of ailment. But all is not lost. Yeah. I want to tell Kenyans that indeed the government is working overdrive to ensure the dream of 100% attainment of UHC is attained in this country.
Okay, Gilbert, allow me to interrupt you there, even before we talk about the issue of low uptake, because for NHIF, these figures are quite good. 10 million is a very good figure. But the problem comes in when only 51% of them are active. It means nearly half of them are not actually active.
Very true, Victor. We have a problem with retention. One, I want to put it, it's the culture that we have in this country that people only seek services when they want to benefit. Thereafter, stop remitting contributions. But all is not lost. We've put into place mechanisms to remind our members to submit premiums periodically. And we've put into place mechanisms to reward our loyal clients. Indeed, we also have come from an area of challenge in the sense that the economy has not done very well after the COVID pandemic. And as such, many of the people are unable to remit their monthly premiums.
Okay. And maybe let me just come back to you then, because Nixon is talking about the issue of adverse selection, where I just pay for a few months, I redeem it. I know I'm now qualified, so I go to hospital and Dr. Timothy treats me. We incur another 100,000 shillings, and immediately, because my problem is sorted, I start defaulting. Is that something common in the private sector as well?
Yes, the issue of adverse selection is heavy in the private sector also. Remember, I mentioned that private sector has tried to develop products to tap into the informal sector. And the main issue has been the people who buy, majority, 80% will be the ones who have a need at that time. And on renewal, you find the attrition is very high. On renewal, they fall off because they already paid for the premium, they have already benefited, then they fall off. They only come back again when there is some issue that needs to be addressed, and which is the major issue around trust, and you mentioned trust, because then in insurance you have to put in place mechanisms to ensure that when you are purchasing, you are just not buying for your immediate need, because remember, we want to pull together to protect a few of us who will get the problem. And that pulling together, insurance companies hold the premiums in trust. We just hold the monies for everybody in trust. We do not want people to come and get into the pool unfairly. So we balance out, and that's what brings the issue mainly around trust.
Dr. Olonyi, if the average figure is 500 per month, at least for out there, it seemed that could be a very affordable figure, considering it's going to cover your entire family. Then why are we struggling with uptake?
I think it still goes back to people have got to see value. in what they're buying. And I think that's part of the challenge, and this is something that people need to address in terms of, are we delivering value for that 500 shillings? And I think there's going to be very little challenge. I don't want to blame ignorance for this. I don't necessarily agree with ignorance, because if it's ignorance, then we know, why have we not addressed the issue of ignorance in terms of people not being aware? I think by and large, a lot of people are aware about it right now. We have to, there's ability to pay and there's willingness to pay. And for those, if you say 500 is affordable, it might not necessarily be the case, by the way, because a lot of people are struggling to be able to put bread on their tables at the moment. So, but at the end of the day, if it boils down to just 500 shillings, I think most people will be willing to do that. In fact, there are a lot of people who take care of that by taking care of anybody who they feel is going to be a responsibility in the event they fall ill. So that issue of being able to design and structure a product that people are going to see and deliver that value, I think is a challenge which we have to meet as a team.
Okay, so now, because for the issue of delivering value, it has to be, as you say, then that I see value in this 500 bob. That means when I go to hospital, I need to be treated. And that brings yet another very controversial issue. Let me just bring in Gilbert back, because Gilbert, a lot of times we get to hear people who talk about, you know, I didn't default, by the way, like the people you are talking about. I've actually been paying for this consistently, for 500 bob or the 1700 the entire year. But when the time comes when I'm in need of help to redeem this and I go to hospital, I'm just told, hey, Sisi, we can only cover 30% of it. You still have to top up from the pocket. And sort of it defeats the whole need of having this cover.
What I want to tell Kenyans, as Brother Olueng has indicated, indeed, for the 500 shillings, which is the premium for the super cover, members are entitled to roundabout 10 benefit package, which includes, among others, inpatient, maternity, we are talking of dialysis, kidney transplantation, the diagnostic imaging, the highly patronized surgical benefit package. We are talking of drug and substance abuse benefit package, overseas treatment, emergency evacuation, among others. On the issue that you raised, that I want to believe relates to the outpatient benefit package, which is also known as capitation, whereby members of NHIF Supercover select preferred outpatient facilities of choice. We have signed up contracts with healthcare providers, and we have indicated the scope of cover of what the outpatient benefit package entails. It entails, among others, consultation with the medical officer of health, drug administration and dispensing, requisite laboratory investigations, guidance and counseling, preliminary radiological examinations, family planning, among others. Indeed, some members, and I want to allude that sometimes there are challenges because of lack of know-how, that some providers do not dispense the requisite drugs. But remember, we have facilities that we have signed comprehensive benefit contracts with. Those are government facilities in contract A, and faith-based and low-cost private providers, whereby you walk in, get treatment, walk out without paying a single cent. But in event you patronize these high-end facilities, unfortunately, you may be compelled to top up over and above what NHIF pays. Okay,
so from the way you're speaking, Gilbert, you're sort of isolating the issue of me having to top up from the pocket to only private, hospitals.
Not all private. I said high-end premium facilities. Remember, there are hospitals in contract B, and I want to update the public that we have 3 different cadres of facilities that are empaneled in NHIF. We have contract A, which are government facilities, contract B, which are faith-based and low-cost private facilities, and finally, contract C facilities, which are high-end premium facilities. For contract A and B, it's walk in, walk out without paying a single cent.
I think we're losing Gilbert there, but I think we asked Kenyans actually their own views regarding the issue, of course, of NHIF. If it's actually working for them. Quite a number of them say it doesn't, some of them say it works. Let's just get to listen to them quickly.
Hakuna haja nikuwe nayo, manake hata nikiwa nayo itakuwa ni mzigo tu kwangu. Ili hata nikuwe na kwa ile private sector ambayo inaweza ikanisaidia wakati nimepatwa na maradhi ama jamii yangu ipatwa na maradhi inisaidie, lakini hii NHIF naona ni kama hainisaidii.
Mambo ya NHIF haifai hata haisaidii mwananchi yoyote. Sababu hata gharama yote yenye unakuwa naye kwa hospitali hailipi yote. Kwanza especially hii mnaitanga hii ya wanafunzi. Kuna mwanafunzi nilikuwa naye referral bili kaenda mpaka 340 na wakalipa nusu, wakalipa 250, ikabidi niingie kwa mfuko. Afadhali hata ukuwa na private insurance yenye najua inakukava kila kitu.
Bima NHIF nilikuwa nimekata, lakini mwishowe niliacha contribute kwa sababu nilicontribute zaidi ya miaka 7 na sikuwahi tumia, na mwishowe nikaona sasa afadhali niwachie hapo nisiendelee contribute. Lakini kuna wengi ambao nimesikia imewasaidia. Kuna my brother pia na yeye ucontribute, niliona ikimsaidia.
Ndio mimi sijakonjeka na niko nayo, but najua itanisaidia. Hiyo najua obvious niko save ikiwa na NHIF. Ndio ina cover pakubwa kwa hospitali. Na naona ni kitu mzuri.
Bima ya NHIF sina kwa sababu niliona pesa yenye inahitajika shilingi 500 kukata maybe ama zaidi ya 200. Hiyo pesa iko juu kulingana na mapato yangu, na sioni kama ni mbaya, ni nzuri, lakini kwa upande wa pesa ndio naona inaweza nilemea kidogo, na hiyo ndio aswa ndio shida kubwa, kwa sababu kuna watu wa mapato ya chini. Mimi ningeonelea ipunguzwe, ikuwe walinganishe watu wote, sababu sisi wote hatutoshani, iwe katikati kadri yenye kila mwananchi anaweza kulipa.
Bima ya NHIF inatumika kwa kila mtu kwa bei nafuu, manake ni shilingi 500 peke yake kwa mwezi, na inahudumia mtu kwa kiwango chochote kile bila ubaguzi. Hata ukiwa mzee bado utaitumia.
Bima yetu ya NHIF ndio bima mwafaka, lakini hii NHIF yetu inatusaidia kwa sababu kila siku unasachangia shilingi kama 18 ama 20 kwa ajili ya siku moja, lakini ukikonjeka inakusaidia. Hiyo sasa ndio bima yenye sisi kama watu wa chini, wa mapato ya chini, tunasaungana nayo na tukaendelea mbele. For example, sisi wanachua kadi unasafunjika mkuu ama mkono, na hiyo kati nayo inatumika kwa ajili ya hiyo pesa ambayo ungelipa pili ya hospitali.
Right, of course, definitely very mixed reactions there from Kenyans from across the country. We asked them, of course, if they have medical insurance cover. Some of them say it has worked for them. Some of them say it hasn't worked for them. But clearly the issue of paying premiums every day, every month, and then when the day of being treated comes, you have to top up, is not isolated to NHIF, even private insurers.
Yes, remember what private insurers do, and if you use Maslow's hierarchy of needs,
yeah.
There is the physiological needs, which insurance tries to help the Kenyan to protect.
Mm-hmm.
So you have your household, and because we are discussing medical, but I just mentioned,
yeah.
You have your house, which provides shelter for you. You have your contents, and insurance comes in to protect those items from any peril or any risk. Risk can be theft, can be fire. So for medical, insurance comes in to support you when there is a bill, a medical bill.
Mm-hmm.
And what insurers do is we do what we call risk sharing, so that we manage the premium. And people can buy where there is risk sharing and where there is no risk sharing.
Mm-hmm.
So when you purchase the one that has risk sharing, it means when you go to hospital, there is some form of payment from you to support your bill.
Mm-hmm.
Insurance will pay up to a certain level, you will pay up to a certain level. That is risk sharing. If you purchase the one that has no risk sharing, insurance will pay. You will go to hospital, you are admitted, insurance will pay, you walk away.
But we still have cases where I've actually taken the latter option, and I still have, we only cover to this part, and I think, Daktari, it almost points to an issue of education. Do they tell me actually what this cover that I am paying for will cover me when I go to hospital?
Yes, I think that's part of the challenge also when people are selling a product. they need to be able to communicate effectively, especially at the point of sale, so that the expectations are clear on both sides.
Managed.
The perception, I think, amongst the public a lot of the time, especially when you hear them bashing in Nhf, is that it is going to be free healthcare from that point on. There is no healthcare insurance that doesn't have limits. So at some point, somebody is going to exhaust that cover. But that having been said, again, when you talk about, for example, and I have to mention the issue of outpatient cover, which my colleague at Nhf mentioned.
Yeah.
They are saying that they're providing outpatient cover through healthcare providers. But are they compensating those healthcare providers sufficiently for them to deliver on that promise? And this is going to be part of the problem.
There's a gap between what the expectation versus what is actually
Yes, for example, if you're going to say that you're going to give healthcare providers 100 shillings per person, all right? 1,200 shillings a year for each person for outpatient cover. Is that realistic or feasible? And I was involved a lot of the time in terms of being able to structure these programs with Nhf, and the agreement was that they were going to use that figure as a starting amount, and then based on the claims experience, this was supposed to be revised. After a while, it became apparent that there was no intention to revise this. In fact, they moved on from outpatient and went to other products. This is going to be part of the problem. You had him saying that there are some providers who are not delivering the province or giving the drugs that as patients expect. But also patients are going to be coming, expecting and insisting and saying, I want a branded product as opposed to a generic because my money came here and therefore I'm already covered. But that is the challenge, because that cover is not sufficient. And I think we have maintained as an association for a long time that you have got to adequately compensate providers for this to be possible. You must understand that those in the private sector, and by and large also those in the faith-based institutions, don't get any funding from the exchequer. So our situation is very different from that in government. So you cannot talk about compensation which is not sufficient and expect that people are going to deliver on your promise.
But Nixon, there's also an issue of how the doctors price this thing. So you have a very sufficient cover, you think it's going to help your, the policy holder, but when they get there, they're told one drug that would go in the market maybe for 100 bob, it's 1,000 bob. So at the end of the day, the benefit it doesn't match really what you expected to cover them.
Yes, and remember, insurance is always enough when you don't have a big problem. When you have a serious problem, it will not be enough.
Do you feel that sometimes some of these bills are inflated?
And the reason why it will not be enough, because there is no standardization of, there is the upper ceiling, there is a standard, but each doctor then, or each specialist charges depending on circumstances or depending on the demand or supply within that area. So you'll find the pricing is not standard.
Allow me to interrupt there, because out there for us, there's the feeling that every time daktari here akisikia tu, they actually ask you, is it for cash or card? And anytime they hear it's insurance, the mood changes, everything gets inflated, you start unafanyiwa tests mingi, sometimes you feel like it's unnecessary. Do you feel the same way as an insurer?
Yes, we feel the same way, although it's not, you cannot generalize to everybody that happens. There are a few of them who will then do quite a lot in terms of over-servicing, in terms of checking what the issue is and doing maybe some services that may not be necessary, and that inflates the bill. Of course, also when they hear insurance, because of the timing of payment, he has talked about compensation. The timing of payment, then medical services also price for that timing aspect. So if insurers were to enable payment prompt, like at AR, what we are doing is to enable providers in future to withdraw money themselves within 48 hours of service. So if insurers were to enable services to be paid promptly, then providers would then be able to keep their prices reasonable and standard.
I'm sure you want to weigh in on that.
I'm usually very, very cautious about using terms like inflated, overpriced. That, let me tell you, healthcare, much as it's a specialized type product, and there's a certain noble things about it, it is still a product like any other, all right? And therefore, people take their pick. And you've got an entire range of healthcare services, by the way. You've got from the low end, even for us in the private sector, we've got very small institutions and very, very far-flung areas in this country. And we've got what we call the Big 5 or Big 10 hospitals. You take your pick according to what you can afford, all right? And that happens both as the healthcare payer and as the patient themselves. But at the end of the day, people's costs are also different. People are different in terms of their costs, in terms of their levels of expertise, and so on. So one thing that you cannot do is go to a particular place and that you provides high-end services and insist on paying the price that will be
that you pay outside there.
Yes.
But let's put that aside for a moment, because there's also the issue now of I mean, even as a hospital and a healthcare provider, it's still a business. So, and you remember, I won't mention the hospital, but you remember the case that was very famous last year of hospitals actually chasing a certain bottom line. We must achieve this per day. So in the end, you end up with a situation where people are forced to perhaps take products or drugs that they probably shouldn't, or even more expensive procedures, like for instance cesarean section, when maybe even a normal delivery would be okay, just because it means more money.
That is good. That is unique. It is unfortunate, but I think it's the exception rather than the rule.
Yeah.
And that's what we said. Let us avoid generalizations. Those things do happen in every sector. There are going to be some players who are going to do what we call churning in terms of being able to provide what he's calling unnecessary services, isn't it? And being able to, you see, we've got an agency problem and asymmetry of information in the healthcare sector. Agency problem meaning you've got somebody who is the one with the expertise who knows what is to be done. But again, he has got vested interest in terms of the more services they provide, the more they get paid. So there's an agency problem there, but there's also asymmetry of information. And this also happens in the reverse. You've got times when you've got people, for example, who are the payers, trying to dictate to healthcare providers what needs to be done. And that, I can tell you as a professional, people take a great exception to. So at the end of the day, there needs to be dialogue, but these solutions need to be come up with together. But in general, the cost of healthcare, let me just emphasize one thing. The cost of healthcare always gets focused down onto, they say hospitals and they say doctors, isn't it? That's what they talk about, the cost of healthcare. But you must realize that the inputs that go into that healthcare product, a lot of them, private hospitals don't even determine the cost. These inputs is what we need to address, whether we're going to talk about UHC or whatever it is. Who determines the cost of drugs? Why, for example, are we talking about healthcare in India being so much cheaper than Kenya? What is it that they're doing different? You go there and the same drugs we buy here go for 1/3 to 1/4 the price that we're selling them in Kenya. Those are things we need to think about. You talk about human resources for health. Is it healthcare providers who determine how much healthcare professionals get paid? And especially with the trend that you have in terms of unionization and industrial unrest, and especially in the public sector, which sets the benchmark for pay. Those are not things that are within the control of the private healthcare provider. So the overall discussion we need to have is about cost of healthcare, especially we push towards UHC.
Okay. Let me just bring in Kalai at this point. Kalai, definitely there's an issue of that perhaps should concern a regulator when in the market people actually pay their premiums very well, and at the end of the day what they get is not what they expected.
Yes, Victor, I agree with that. But like Nixon said, you have to know that the insurance is a contract. And the contract is very clear on what is covered. Maybe what may be lacking is understanding, because it's very clear in the policy when you are given that if there are limits, they are very clear that we cover this item up to this limit. That they are all put in the policy document. So maybe it's an issue of understanding and awareness on exactly what cover we are getting. Like it was said from the beginning, these covers are not unlimited. You can't give unlimited covers. So and you buy what you can afford. And so you should know exactly what you afford, so that when it comes to getting a space, you are not disappointed. Thank you.
Okay, let me just bring in Gilbert at this point, because just a few days ago we interviewed the CEO, that is Dr. Kamunya, and he spoke about the investigation into 19 medical service providers who are under investigation for engaging in medical fraud, which contributed to unjustified claims borne by the NHIF. Let me just get your brief reaction to that before we come back to the issue of cost of healthcare. Gilbert.
Thank you, Victor. Indeed, the issue of fraud is a serious challenge to healthcare in this country. Remember that one of the cost drivers that has made healthcare unaffordable in this country is because of fraud, and it cuts across board, from the providers to our members, even on our side. And very little research has been done on healthcare fraud, but I'm happy the Association of Kenya Insurance commissioned a survey on healthcare fraud in 2013. And according to the report, medical insurance has the highest loss ratio, which stood at 81.5% for the year 2010, with an average loss of 78% over a year for a 5-year period. You'll notice that many healthcare insurance providers have closed shop, partly because of the issue of fraud. But want to inform the public that there are healthcare provider key indicators and red flags that they should be aware of, and I had Timothy mention them. We have instances whereby doctors perform medically unnecessary services solely for the purposes of benefiting. Cases like unwarranted admissions or unnecessary laboratory investigations. We have billing for services that were never rendered, using genuine patient information, sometimes what we call identity theft, and people fabricate and generate claims.
Yeah.
We have the issue of falsifying claiming documentation by overstating days that patients were admitted in the ward. We have upcoding of bills costing for services that is higher than what one performed, and bundling. We have instances of where providers accept kickbacks for patient referrals and many others. But at NHIF, we've put into place mechanisms to ensure that we cushion NHIF from these issues of fraud, wastage, and abuse. As our CEO indicated, we've set up a forensic unit that has been tasked to investigate instances of fraud.
Okay.
But again, we have undergone digital transformation whereby we've moved to the digital platform. We've put into place what we call biometric identification, authentication of our members at the point of seeking services, which will enable us to minimize issues of impersonation. And the biometric authentication comes with a number of benefits, which include, among others, high security and assurance.
Okay.
The biometric identification provides answers to something that is personal. No one can be able to fake your biometrics. It's also convenient and fast. And the other thing, it's non-transferable. What I want to tell our viewers this morning that currently we are carrying out biometric registration across the county. And what we are doing, we've deployed units to register people in our point of service.
Yeah.
That is our branch offices. And for that matter, we have 156 service points, which include 70 branch offices, 33 satellite offices, and 53 Huduma centers.
Okay.
Yes, Victor.
Yeah, you're finalizing, yes.
Yeah, we've also partnered with healthcare providers to register our members at the point of receiving services.
Okay.
The other thing we've done, because I know time is not on our side,
yeah,
is that we've deployed electronic health records, or e-claim, whereby providers are now compelled to file their claims online, which will reduce, among other things, wastage and time wasted when filing the paper e-claims that they used to file manually.
Okay. And maybe before we take this quick break, then Nixon, you can respond to this, because he's raised the issue of how this affects the bottom line for insurance companies. And apart from 2020, which of course you did very well, and it could be attributed to fewer people going to hospital because of COVID, the other years we saw quite a number of medical insurers really taking a heavy hit, and very few of them actually breaking even or even registering a single shilling in profit.
Yes, the main consumer of insurance premium is claims, and which is why insurance is there.
Yeah.
So insurers have been mainly private, and I think I met the CEO of NHIF, and he was indicating even NHIF has had the same hit, have had high claims in terms of over 70% of the premium goes to paying off claims. Some of those claims have issues, like he has mentioned, that either they are marked up, or they have members who are not supposed to be accessing service, and therefore affecting the bottom line for insurers. Of course, you remember insurance premiums, once you collect, there are several, you still need people to offer to service those customers. So you need to pay them, you need to pay for the claims. And that's why insurance companies have had losses in this medical insurance. We thank God for AR. For the last 3 years, we've been able to make a little profit, but not what we call underwriting profit, because underwriting profit signals that the technical business itself is doing well, but not investment, because you see the premium you get, you also invest, which leads to generation of some profit, which is what most insurers have been surviving on.
All right. Super. Of course, we have to take a very quick break, but don't go anywhere because all my guests are staying with me. When we come back, we talk about the way forward. What can we do to bring more Kenyans on board and have medical covers? We also come back with the set of feedback that you've been sending them. Keep sending them on Twitter. Maybe we can sample some before we go. Emmet says most reasons are due to compensation, which most insurance companies frustrate. I think we have highlighted that. Thank you, Emmet. We have Jacob who says most they are expensive and unreliable. Most of the time they want to claim. It becomes a cat and mouse game. Majority Kenyans no longer trust anything insurance. Thank you, Jacob, for your feedback. And we have Bianca who says great topic. Healthcare insurance is undermined, more so when you finally need the much needed care. Thank you, Bianca. We have to take that quick break now. When we come back, of course, we sample more feedback. And of course, we talk about the home stretch of this conversation, which is to bring more Kenyans to have medical insurance covers. Don't go anywhere.
Just one capful of Dettol is enough to disinfect surfaces and protect your family and your home. Dettol, tested effective against COVID-19.
And kama kawaida, people politicize that too. At why would the president leave his deputy to go with the leader of opposition? I thought that was one of the rules. No one was supposed to go to Naivasha with their main partner.
Unless you've been trained to a skill level where you can afford to do that, it would not be something which I would encourage anyone to do. Because the split of that trigger going, it means the life has been taken.
Na mimi naweza ishi kama fingerprints zangu zitaniletea shida.
Unajua sasa kwa fingerprints zako siwezi nikakwambia itakuwa zitaleta shida kwa sababu already iko immunized, lakini kwa sababu ya corona kwa sasa hivi nikishika nikikupatia itakuwa shida, si ndio?
I know, ni tamu. It's no surprise. The good quality baked bread from Bol A is festive bread. Chukua yako moja leo.
Invest from Finca Properties. A gated community ready for immediate development. We also have Konza Suburbs, a gated community within Konza Metropolis. For details, call us today. Finca Properties Limited, prime and affordable.
Thank you for staying with your world on NTV. This morning we are talking about medical insurance in Kenya, health insurance. How many people have medical covers today? Why are people not taking up medical insurance covers, especially during this time of COVID-19? My panelists this morning helping us, of course, delve into this discussion. Dr. Timothy Olweny, the Secretary General of the Kenya Association of Private Hospitals. Nixon Shigoli, the Managing Director of AAR Insurance Kenya, Gilbert Osoro, the Manager of Universal Health Schemes at the National Hospital Insurance Fund, that is NHIF, as well as Kalai Musei, the Chief Manager, the Technical Department at the Insurance Regulatory Authority. Gentlemen, let's just pick up with this question that we have from one of our viewers. And it says, Tom says, my friend's daughter who pays for NHIF needed osteology surgery, and she was referred to a public hospital by a public hospital to a private one. The bill was 300K, and the NHIF paid only 75K. Now, if you go to a public hospital and you're referred, what do you do? Gilbert, let me just get you to respond to that briefly.
Thank you. I note that the member was referred from a public facility to a private facility. What I want to say that there are national referral guidelines that have been put into place by the ministry. You can refer people vertically or horizontally. But above it all, we have signed contracts with healthcare providers and how much they can charge for specific procedures. And I want to believe the member could have visited one of the high-end premium facility, and that is why the bill went to 300,000. Ordinarily, for the procedure undertook in a government or a faith-based institution, the amount was sufficient.
Okay. And I think that let me just bring you into this point, because there's also the issue of sometimes you come to the hospital, Dr. Olowen should be treating me, but they charge me the 3,000 or 2,500 for consultation, and then they tell me, you know what, you can go buy this drug somewhere else. So it almost points to almost selling advice and not really treating me. And then I'll come back to you on something else. Just briefly respond to that.
I want to be clear. Are you talking about consultation in the private sector? In terms of
yes, because there's an issue of people who really come here for treatment, but then you get directed somewhere. You can go buy this elsewhere, and sometimes you find the place where you can buy this drug do not accept the insurance cover that you have, and you have to go back into the pocket. And it raises the question then of, when we are onboarding these hospitals, are we looking to see that they have sufficient drugs that could treat people? Just briefly respond to it.
I think in general, the hospitals who are impaneled, by whether it's by insurance companies, whether it's by NHIF, private insurance or NHIF, have got the capacity to deliver the services. Otherwise, they will not be impaneled, isn't it?
Let me hold you there, because I think in 2019, actually, and maybe Gilbert can respond to this, there was the issue of how NHIF was onboarding hospitals. This specific hospital in Umoja had been paid 63 million by NHIF. And this, when the investigating team, the board visited, they found out that this specific hospital had no compound, no branches at all, but still managed to be selected by all employees of a strategic agency, no matter where they lived across the city.
Is that a medical facility, what you're describing? You see what, let's be clear. First of all, as a association of private hospitals, don't equate that to meaning that anybody who is not private, not government and not faith-based is one of our members. Secondly, yes, we are only dealing with people who are duly registered and registered by the medical board and all the relevant bodies. Now, if you talk about a situation like that, as far as I'm concerned, that's not even within our realm. NHIF themselves need to explain how they handled that person and how they went ahead and made the payments. That really has got nothing to do with us, because that's not our member. As far as I'm concerned, based on what you described, it's not even a hospital.
So as an association, do you then, looking at your membership, these are people who are credible, don't have issues with how they settle claims?
We talk about greens fees. For you to be able to play, you have to meet the minimum requirements. You have to be a registered institution. Institutions are registered at various levels, and then you have got to have the personnel that are required and the capacity and all the services that you promise to deliver. Then that is when you become our member, isn't it? And based even on the statutory bodies, whether it's a medical practitioner, dentist council, or whether it's NHIF that is going to be impaneling them, or even the private institution, private health insurance, they don't just take anybody on board without actually visiting the facility and knowing who they are sending the members to.
Let me go back to Gilbert. This was really a concern, especially on how the management, how NHIF in itself as an institution is being run, and I think it's probably part of the reforms that you're implementing right now, because there have been questions on how do we select a hospital? What do we look at before we select that this hospital should be onboarded as part, of course, or empaneled, as Timothy would call it?
Thank you, Victor. To put it into proper perspective, the mandate of accrediting facilities is domiciled with the Kenya Medical Practitioners and Dentists Board. If you look at the NHF Act, the provisions of Section 30, which state expressly that the Board of NHIF, in consultation with the Medical Practitioners and Dentists Board, can declare any nursing home, maternity home, or hospital for purposes of this act to be a hospital or a healthcare provider.
Yeah.
Ours is limited to declaration. The function of accreditation is at the medical board. So for us is to take the licensure that has been issued by the board, but we do undertake due diligence to verify beyond reasonable doubt that the facility meets the cut.
Okay.
I know indeed we come from an area of a challenge, especially on the issue of contracting, whereby some facilities duped both the board and NHIF to obtain licensure. And as such, we've put into place mechanism to remedy the situation. As we speak, the current contractual cycle ended in June, but we extended it for 3 months to provide space for fresh assessment of all healthcare facilities that are impaneled in NHIF.
Okay. All right.
Yeah.
And maybe before we look at the amendments for the NHIF bill, let me just have you respond briefly to this, because there's also the issue of how quickly insurers approve, payments, or at least give the go-ahead for daktari to treat people. But when we have an issue of fraud in the industry, it kind of gives you a challenge of finding the balance of quickly meeting the needs of your clients, which is to quickly approve, but at the same time scrutinize and see that there's no...
Yeah, you have articulated it well. Usually there is a challenge of ensuring you are approving the right treatment, for the right member.
Yeah.
So there is usually the issue of identification, which happens, and most of us, even at AR Insurance, we are using biometrics. And then there is the issue of what is being treated, because you see, you must define what are you treating.
What are you treating?
So then it will take time, depending on when investigations will be done and establish exactly what is being treated. Remember, the public needs to know, sometimes when you walk into a hospital and you have a headache, they need to do some level of diagnostic investigation on you to be able to determine what is the cause of, it's not maybe just a normal headache. What is the cause? In the process of those investigations, some results take time. So insurers will wait until they have disclosure or medical report saying, this is what we've discovered and this is what we are treating, so that then they can go and apply the terms of the policy, the terms of the contract. If whatever is being treated falls within a sub-benefit, then you are able to say, okay, fine, we'll pay for this claim up to 1 million, for example, because it falls under this. Without knowing what is being treated, it becomes very hard to give an undertaking. First, we give an open undertaking, proceed, do investigations, give us the diagnostic, we give you a commitment for the whole bill, or for the bill, for the limit that the member has. That's what happens.
Okay. Gentlemen, I want us to talk about what can be done then to bring more people to be covered. And I'll start with you so that as we progress and touch on this NHIF amendments which are already in Parliament. From where you sit as a private insurer, what needs to be done to make sure that because if there's anything that COVID-19 taught us, then it is the importance of having an insurance, a medical cover.
Yes, a lot can be done to ensure uptake of insurance is improved. And remember, you cannot do it without some premium. For motor insurance, for example, there is some compulsory insurance. There is third-party insurance which you must have. I think that is the effort you are seeing in Parliament around NHIF, trying to say, then it becomes mandatory for you to have NHIF cover. How it will be implemented is what then needs to be looked at. So in medical insurance, there should be some form of compulsory insurance, some form of basic primary compulsory insurance for medical. And that can be thought through. It's not that I have any clear thoughts around how do you make medical insurance compulsory, but NHIF through the bill maybe would achieve some of that level of compulsory insurance. The other thing is, remember, most buyers, like Kalai said, are sponsored by corporates, by groups, employers. So individuals don't willingly come and buy insurance. And we need to take that into consideration, that corporates are the ones promoting most of the private insurance. And even And even NHIF.
And maybe we can bring Dr. here, because a huge part of our economy is driven by the informal sector. And if we say then that, you know, only people in the formal sector can have insurance or should have insurance, we're literally leaving the entire country behind.
I think other than talking about insurance alone, by the way, we are talking more about the wider debate in terms of pushing towards universal health coverage.
Yeah.
And insurance is one of those components, because for you to achieve UHC, you need to be able to get, first of all, pooling mechanisms via which, so the only way you can achieve this is either through a tax-based system, which is through government, or through private insurance, or a social health insurer like NHIF is trying to be transformed into being. But the challenge that we have is that a lot of these things, we talk about health being, for example, universal, are right, especially in our constitution since 2010.
Yeah.
Let me play the devil's advocate here. Is it something that's even realizable? Is it realistic? Is it something that is enforceable? Is it justiciable? In other words, I'm saying, can you go to the street, as we're talking about mandatory health insurance? Are you going to arrest someone and tell him I'm taking him to jail?
Like
because
you
don't have
arrest them for a mask.
Yes, because you don't have health insurance.
Yeah.
Some of those things you have got to view it, and we have to inject some realism into it.
Yeah.
So the mechanisms by which, for example, with the Amendment Bill now, I think people in general mean well. But I think in terms of the thought process and in terms of execution and in terms of stakeholder engagement, we have failed, because we shouldn't be at the point where we're talking about a bill that is in Parliament already, and you've got all the stakeholders being invited to be able to participate in public participation at the 11th hour.
Okay. Let me just bring in Kalai briefly before I go to Gilbert. Gilbert, I mean, Kalai, on the face of it, this at least should help us increase that issue of having more people, you know, get insurance covers, medical insurance covers. Kalai? Okay, let me just go to Gilbert then. Gilbert, there's clearly an issue here. One of the recommendations, or one of perhaps the tenets in this bill, the Nhf Amendment Bill, which is in Parliament right now, I'm not sure if it's the second or the third reading, is that we actually make it mandatory for literally everyone in this country and every household to have insurance cover. And I think Dr. Olwenyi has raised a very valid point. During this time of COVID-19 and people are struggling, is it really enforceable? Is it realistic? Can we go to the street and say, where is your NHIF, card?
Thank you, Victor. I'll start by quoting one of my favorite writers, who's called Eleanor Roosevelt, who said that the future belongs to those who believe in the beauty of their dreams.
Okay.
When we're talking of universal health coverage, it means that all individuals and communities receive the health services they need without suffering financial hardships. And this includes the full spectrum of essential quality health services, from health promotion to prevention, treatment, rehabilitation, and palliative care. I'll go straight to the point that you've raised pertaining to the Nhf Amendment Act 2021 that is currently on its second reading. And as we speak today, the Parliament is doing stakeholder engagement. We have professional bodies that are contributing or putting in their petitions in relation to the amendment.
And maybe if I can hold you there, Gilbert, Dr. Olwenyi here feels that these stakeholders that are coming at a very later stage of course, this process, they probably should have been involved from the word go.
I want to respond to the issue raised by Dr. Olwenyi, that we had what is known as HEFREP. The then CS Cecily Kariuki in 2019 unveiled the Health Financing Reform Expert Panel, whose broad mandate was to suggest reforms for transforming the 52-year-old NHIF into a vehicle for delivering universal health coverage. The panel held several workshops and engagements in town halls with key stakeholders, including the Kenya Association of Private Hospitals, where Olwenyi sits. The objectives of the engagement were to obtain stakeholders' view about the experiences in NHIF, identify gaps, and reform recommendations. And they came up with 55 recommendations that were put in the HEFREP report that was to transform and reposition NHIF as the vehicle through which the government intends to attain UHC. Among the reforms that they put forward is the expansion of healthcare providers network to enhance access to healthcare services to our membership. Towards that end, NHIF has empaneled 8,189 healthcare providers as at June 2020, from the panel that was there in 2019 of 4,218 declared healthcare providers. The other thing they recommended was reduction of Nhf administrative expenditure. And there's been progressive reduction of administrative expenditure from 22.2% in 2016 to the current expenditure that is at 11% at the close of the financial year 2019-2020. They also recommended the review of the Nhf organizational structure. These opinions were presented by the stakeholder, and I want Oluwen to bear testament. Some of what they recommended is what the committee put. And towards that end, there was recruitment of a new CEO in April 2020. There was Nhf staff reorganization, whereby they are aligning and balancing the human resource skills to key functionalities for efficiency and job satisfaction and career growth. There was the upgraded customer care experience, whereby Customer Experience Center began operations in 2018 by opening up a toll-free customer care center that operates 24 hours a day, and currently we receive in excess of 3,000 phone calls a day. Then the Nhf Amendment Act, which I wanted to go into, I hope you'll give me time to explain. It also recommended transformation, members and employers, transformation to the digital platform, whereby we've rolled out the Nhf Self-Care Platform, which is a platform whereby members can register, check the dependents that have been captured in our database, check the status of pending pre-authorizations, check the benefit matrix that they're entitled to. I'll stop there because there are quite a number of measures that they had recommended, but that is a nutshell of what the HEFREP report recommended.
Briefly, I want you to respond to this, Gilbert, because there is another very controversial issue, right? There is the requirement for employers to sort of give an equal contribution, the same that, of course, is being contributed by the policyholder, the same way it would be done for private insurers. And the problem with that is, I mean, it would feel for Nixon and others, in this case, that maybe NHIF is trying to crowd out other private insurers.
Perhaps I'll want us to look back down memory lane. Over the years, our members, and when I say our members, it includes members of private health insurance. NHIF has been the primary insurer when it comes to settling of bills. And you realize, even you, Victor, if you have a private insurance, in the unfortunate event you're admitted in one of these high-end premium facilities, they will tell you that let NHIF settle its part, then we top up, despite the fact they are the main insurance guys that you've taken. Now, I'll respond to your question. For the first time, we've had a shift from members financing the insurance cover to a shared responsibility, whereby the employer and the employee both contribute towards an enhanced cover. I want Kenyans to look at the bigger picture. When we talk of UHC, and we are talking of financial protection, protecting people from financial consequences of paying health services out of their own pockets. We cannot secure financial protection by the member contributing himself. And in this case, we look at people who are in employment. Remember, they are contributing from 160 shillings to a maximum of 1,700 shillings per month. For us to attain UHC, so that we cushion these people, we need the employer to match the contributions. But we might end up missing the picture if we do not look at the bill from an holistic perspective.
Next,
we are talking of increasing the scope of cover. We are talking of, in future, having dialysis patients get 3 dialysis sessions in a week. We are talking of, for the first time, allowing children, and when I talk of children, if you look at the Amendment Act, what we call definition of terms, in the Nhf Act number 9 of 1998, it defines a child, meaning a child of a contributor, including a posthumous child or a stepchild or an adopted child, who the parent stands in what we call loco parentis, who has not attained the age of 18 years, or having attained the age of 18 years, but not 21, but in a full-time institution, to be a beneficiary. In the new Amendment Act, they've removed the cap of 18 years, and they've extended the ceiling of children up to the age of 21 years.
Okay.
Remember, the biggest challenge we are facing in this country is youth unemployment. Even up to the age of 21 years, children are not engaged in gainful employment.
Thank you.
For the healthcare provider,
allow me
is
to
good news.
Yeah. Allow me to get Nixon then and a healthcare provider to respond to this. First of all, I want you gentlemen briefly to respond to the two issues. Number one, which is compelling, of course, employers to match the contribution that I make personally. And then number two, which is very of interest to you, now having NHIF to come in as a sort of last resort after, and have, of course, the private insurer to take the first charge.
Yeah, first I'll start by saying private insurers have always supported NHIF in the whole uptake of NHIF, because all our members, the first precondition is they must be members of NHIF. So in our pricing assumptions, or when we are determining the right price for the member, we take into consideration that there is the first bill that is paid by NHIF. So we net it off. It is not that when we don't pay it, it becomes profit.
Okay.
So that's the first thing. And then number two, you've heard clearly, most of the members insured in private insurance, even in NHIF, are from corporates, from the formal sector. Now, if you ask the formal sector to double the contributions, it means there'll be a double increase in cost. And given this time of COVID, you know, some people lost jobs, some companies are struggling. So that becomes another extra cost for the employers. Now the employers will have to determine whether they will need to have a private insurance and NHIF.
Or NHIF. Yeah.
So therefore they'll choose one.
Yeah.
And if they choose one, even the issue of who pays first ceases to be there. Because you are the only one, so you will pay all the bills. So you've not managed to achieve the objective you had there. The other issue is, for example, if I contribute the maximum, 1,700 times, and then my employer contributes 1,700. That is 3,400 per month.
Per month, per person.
Times 12 is around 41,000.
Yeah.
Now 41,000, if I compare the services I'll get from private and what I'll get from NHIF, both outpatient and inpatient, will there be value? He talked about value. Will I be able to be allowed to access 3, 4, 5 hospitals or one? If I have dependents across the country, will I be able to pick all the dependents where they are and be able to access service? So what I think NHIF would consider is doing what we call contribution, which is a principle of insurance. If your cover is 10 million private and I cover you 5 million, we come together, the bill is 2 million, we contribute depending on how much each of us is bringing on the table. That would be a better compromise for that particular aspect. And I think the last aspect was the issue of, which I've covered, employers doubling.
And I think that is important considering how private medical insurers are already struggling. So if they become the first charge, it could mean death. But anyway, I'll allow Dr. to respond from where he sits.
Allow me to respond first to the issue that Osoro raised about being on the HEFREP panel. I do agree. We also participated in that. We gave our submissions, and I also personally gave an oral submission to that panel. Secondly, now we've got the Nhf Amendment Bill, which says stems from that. If they stayed licit to whatever the contributions were, why do we have so much in terms of headwinds? You know, there's one thing about giving your contributions, whether they're taken into consideration is another issue.
Otherwise, right clearly now, from the reactions, FKE, AKI, quite a number, COTU, quite a number of stakeholders.
So that is clear. That is testimony to the fact that clearly they did not take those things into account. That is where the problem is. On the issue about first loss and the NHIF being now switching things and saying they're going to pay after the private insurers have paid, I think one of the challenges we have here is when we talk about, first of all, for example, matching. When you talk about matching employers' contributions, it's the issue of value. They're telling us they're going to double contributions from the formal sector.
Yeah.
There's no mention about what additional benefits we are getting for this double contribution. That is significant.
I think there's some bit of mention, by the way, but anyway, just proceed.
And it's significant. I'm a healthcare provider, and I'm telling you, for now, I want to clearly hear what enhanced benefits are we getting for the double contribution.
Okay.
When it comes to insurance, I do agree that there might be the presumption. I don't think it is very specific when people are getting private insurance policies that they say you must have NHIF. It could be for corporate groups. The presumption is there because if you're a corporate person, automatically you contribute to NHIF mandatory. For individuals, that doesn't come. It comes at the point when you're paying the bill, then they say net of NHIF. And this is part of the promise. People are saying, when I was getting your insurance, I was getting it because I don't want to deal with NHIF or to go to public sector or whatever. How is it now, at this point, you're telling me now, are we going to pay net of NHIF? So that's about a promise, and that needs to be addressed. But secondly, when they talk about net of NHIF, when they're pricing their premiums, when NHIF enhanced the benefits, we didn't see a commensurate reduction of those premiums. So also we have to be, to speak the truth on both sides. Let us be frank about what kind of profit margins we are making. And when NHIF enhanced their benefits, there also needs to be a reduction in premiums to reflect that benefit, because the perception now is that private insurers are pocketing that additional money. When they tell you now NHIF is paying for surgery, they were not paying for it before, they say let NHIF pay 75,000, we'll top up. But at the time of getting the premiums, this benefit didn't exist. So that's a discussion we need to have.
Okay. Gilbert, I'll give you 1 minute to respond before we take this quick break. Respond to what Nixon, of course, and Dr. Olweny have raised.
Yeah, I've heard what they've said, and what I want to say, not to miss the point, we are having a paradigm shift from what we call an input-based tax system, input-based insurance, to a tax-based healthcare insurance. Now, having said that, yes, indeed, we realize that for the first time, insurance providers are worried because over a long period of time, NHIF has been carrying their back. For the first time, they will be the primary insurer, because remember, for us, the members who have secured private insurance are members of the super cover scheme. Some of them will contribute between 160 to 1,700. But many a times we pay threefold of whatever they've contributed towards their medical expenditure. But on the issue of the Nhf Amendment Act, which is the focus that emanates from the HFREP report, there are a lot of gains that will accrue from that particular bill. And I want to tell providers, and Olweny is one of them here, that the effect of the amendment will mean that for the first time, we have opened up accreditation to other professional bodies. We've been accused of the recent past that accreditation was only limited to the Kenya Medical Practitioners and Dentists Board. In the new amendment bill, we've recognized other professional bodies like the Kenya Clinical Council, Nursing Council of Kenya, Kenya Medical Laboratory Technicians Board, and others.
Okay.
There are quite a number of things that accrue to this bill. If time allows, I'll be able to share.
Okay. All right. Gentlemen, of course, we have to take a quick break. We are talking about medical insurance in Kenya. We have to take a quick commercial break. Don't go anywhere, because when we come back, this gentleman will stay with me and we wrap up this discussion. Remember, today is July 1st, which means, unlike other days, we are actually going to close the show with some good music because it's World Reggae Day. Anthony Osol, my colleague, is at Nation FM, as well as DJ Mo Spice. They'll give us some good vibes at the end, of course, of this show. So don't go anywhere.
StarTimes, Get connected today for only $9.99 aerial decoder and $2,699 satellite dish.
Startups. Enjoy digital life. Did you know? Did you know at Ruiru Mabati Factory you can open an account and lipa pole pole at your convenience? Did you know at Ruiru Mabati Factory you can get customized sizes according to your roof plan to avoid wastage? Did you know Ruiru Mabati Factory offers free delivery countrywide within 72 hours? Call us now on 0111 050 700. Ruiru Mabati Factory, mali safi kwa bei poa.
And now, this week on The Trend. And of course, tutakuwa na Sikam the Storyteller.
Ati puff hivyo ndo vijana wa campus wana lose cash. Deep thoughts kwa shallow cups za bia wanarosha dandefu kuliko life zao.
Kipindi si kipindi bila the host with the mostest, naongelea Amina mwenyewe, na pale kwenye santuri tutakuwa na DJ E.
Nakwambia shida zako ni ndogo de.
Yummy. I know. Ni tamu. It's no surprise. The good quality baked bread from Bol A is festive bread. Chukua yako moja leo.
Invest in the prime plots from Finca Properties Limited, Equator Gardens Nanyuki, a gated community ready for immediate development. We also have Konza Suburbs, a gated community within Konza Metropolis. For details, call us today. Finca Properties Limited, prime and affordable.
You are watching Your World on NTV this morning. All my guests are staying with me as we come to the final lap of this conversation. We are talking about medical insurance in Kenya and why every Kenyan needs to have a medical cover. Kalai, let me just start with you. Even during all this issues and melee and chaos that we have, we should not lose sight of the fact that the end goal, I believe, at least from where I sit, is to make sure that everyone is covered, has a medical cover, and they do not have to pay for health care directly from the pocket. Kalai?
Oh, okay, Victor.
Yeah.
That's very true. Our goal is to make sure everybody is covered. And I want to report that the authority has now put in place what we call microinsurance regulations.
Okay.
And the aim of these regulations is actually to bring in new players to give different covers which are suitable for the bottom of the pyramid part of our population. So from this year, we are actually now receiving applications from people who want to go into that area. And we will be seeing new products which are purposely made for the bottom of the pyramid. Thank you.
Okay, all right. Let me just come back to you gentlemen, because I think we need to wrap up this conversation. What's the way forward, really, from where each one of you sit? And I think, let me just start with you, Dr.
I think the way forward in terms of trying to achieve universal health coverage is to be able to have a more systems approach, involve stakeholders, set our priorities, and look for a realistic way of being able to take steps towards achieving universal health coverage. You know, even when we talk about the right to health, health, if you look at the WHO definition, it's actually an aspirational goal, but you cannot ever have a state of physical, physical, social, and mental well-being for everybody. So health, even if we talk about it as a right, health is a right, yes, but it is something that is aspirational because you distinguish between the right to health, the right to be healthy, and the right to healthcare services. I think what we're talking about here is the right to healthcare services, to be able to, for you to aspire to be healthy. But that might not be attainable for everybody. But as we do that, let us involve all stakeholders. Let us make sure that we take baby steps towards this. What we're trying to do is take large leaps, but it might be a leap in the wrong direction. And that's the challenge we have, especially with some of the bills that are being floated now. They mean well. But I think in terms of execution, planning, and then therefore execution, we're going to have a challenge.
Okay.
Yes, for private insurance, there is need for private insurance to support UHC. So therefore, the designing of how NHIF gets to handle members should be done from a perspective of primary insurance or primary healthcare, and more secondary and tertiary healthcare handled by private insurance. So I think both the private and the public sector needs to work together for UHC to be successful, because any of us, or both of us, are important in the whole mix of ensuring everybody gets the right healthcare in the industry. And in insurance, they are like in AR, we've developed products that therefore do not have conditions and do not have requirement for NHIF. And for those who can be able to, and remember those products will be slightly pricey at what is calling premium, so that those people who want premium service get premium products.
Okay, but if these products are premium, because my understanding is if you're designing a product that does not require the policyholder to have an NHIF, that's probably targeting someone who's not employed, right?
There are some people who
because most employers require that you have NHIF.
Yeah, like what he said around the retail business, because you see the people, many people are not attached to any organization. And there is a whole almost 11 million principal members or families on the retail side who are not attached to any organization. They are doing their own informal personal business.
Okay.
Those are the people we are targeting with such products. And they may not, although with time then this will be required that they must have NHIF, but then they may not need NHIF. That's why that product is there. But what I'm saying is that we need to complement each other. The public sector and the private sector need to complement for achievement of UHC.
Okay. Daktari, voluntary or mandatory? Which one would you go with?
You know, you can't make it mandatory if it's not possible. I'd say you encourage voluntary, and then for those who cannot be able to afford, where it is determined that they're not able to afford the care, government needs to step in. And that's one of the roles by the government is supposed to do in terms of achieving UHC, is anybody who is regarded as indigent, I don't like that term, but anybody who is economically disadvantaged should have payment made for them. Of course, the challenge is in terms of determining how do we get there. One other thing I want to mention, this thing about high-end and premium, we keep talking about it like it's a bad thing.
Yeah.
Are we not proud to have high-end healthcare and premium services in this country? We also deserve it, yes. But it seems to be being mentioned every time, high-end premium in a negative, with a negative connotation. We should be happy that we've got those high-end hospitals and we can get premium services in this country.
Okay. Gilbert, I want to give you just exactly 1 minute to give us your closing remarks.
Victor, I want to tell Kenyans that we at NHF, we've upskilled the UHC uptake. We've put into place a raft of measures to ensure that we onboard as many Kenyans as possible. Remember, the President launched biometric registration and verification of indigents in Mombasa in October 2020. And the national government and county governments agreed to onboard 1 million households that will be spread across the 47 counties. At NHF, we have embarked on biometric registration of both our members and install eClaim. Currently, we are engaged in negotiations with county governments and national government CDFs to see how they can onboard more indigents to NHIF. We are currently at the final stage of rolling out the harmonized benefit package. Daktari asked that they are yet to hear what the new UHC package is all about. But I want to implore them that the proof of a pudding is in the eating. I want to rest it there.
Okay. Thank you. Kalai, from a regulatory point, just give us your parting shot.
Okay, thank you. I think for me, the cake is big enough for all of us, and we need to work together because our goal is the same. We all want to have everybody access quality health care. So we just need to work together so that we ensure that we achieve that objective.
Okay. Yeah.
I don't think we should make it like a competition. We want to attack each other. We just need to work together and we can achieve that objective.
Okay. Gentlemen, 40
Thank
seconds
you.
each. I'll start with you, Nixon.
Yes, and this topic is to the heart of AR because we are among the top providers of healthcare in Kenya, and our specialty is around providing products that address the needs within the population. And because of that, we've tried several products. Among them, a product that you can pay only 8 shillings per day to access healthcare up to 500,000 shillings. So what I would encourage Kenyans, it is important to have insurance because insurance comes to protect your income, which then protects your basic needs because your income, in case of any eventuality, is protected.
Okay.
Thank you.
Dr. please.
The private health sector provides upwards of 50% of the healthcare needs of Kenyans at the moment. So for UHC to be achieved, the private health sector must be actively involved. That having been said, the private health sector is more than willing and actually optimistic that we are going to take strides toward that realization. But the key thing is we have to be able to structure our systems in such a way that funding for healthcare is done. We minimize out-of-pocket expenses, and therefore people paying for services at the point of service is minimized. That's the only way we can be able to achieve this, but we also have to aspire to quality. One of the key things about UHC is not just access. We hear a lot of talk about access. It is access to quality that is sufficient to be effective.
That part is not mentioned.
That quality aspect is important. So it's about
because
access.
You can build dispensaries all over the country.
It is about quality.
They have painkillers only.
Access to quality, and then there's aspect of financial risk protection. That's where the insurance and pooling of funds comes in. So we're optimistic that the government and all the stakeholders in this exercise mean well, amendment bills and so on, but they need to be well thought out for it.
But as a doctor, for any Kenyan who's watching right now, they're still ish about this thing of having a medical cover. You saw some of those residents from Eldoret who were saying, me, I paid for 2 years and nikasema wache ikae.
There's a lot of work to be done in terms of what we promise and what we deliver. I would rather we over-promise, under-promise and over-deliver, but at the moment it might be the reverse.
Over-promising and under-delivering.
Yes.
All right, what a wonderful discussion we've been having. We've been talking about medical insurance in Kenya and what needs to be done to ensure that more Kenyans actually take up medical covers. Many thanks to my guest this morning. Dr. Timothy Olweny is the Secretary General of the Kenya Association of Private Hospitals, joining us in studio this morning, as well as Nixon Shigoli is the Managing Director for AAR Insurance in Kenya. Also, many thanks to our guests this morning joining us virtually, led by Kalai Muse, is the Chief Manager for the Technical Department at the Insurance Regulatory Authority, and of course, Mr. Gilbert Osoro, who is the Manager, Universal Health Schemes at the National Hospital Insurance Fund, that is NHIF. From me and the entire team, it's goodbye for now, but just a reminder that it's 1st of July. That means it's World International Reggae Day. Oh my God, who doesn't love reggae? On the other side, of course, of our studio, that is at Nation FM, Antonio Sol and DJ Mo Spice have something wonderful for us. Anto, Mambo Vipi, what's going on?
I'm good, man. How are you doing? Well, it's true. If you don't love reggae, man, you need to be very worried if that person doesn't love reggae.
Does anyone like reggae here, by the way?
It is International Reggae Day. We're going to put a reggae.
Kabisa. You should start with this. Strangers in the Night. Strangers in the Night.
Oh, wow, you do know reggae. Every dance kidogo reggae nione watu wana dancing na sisi nakaaje.
All right. Let's go.
Of course, it is International Reggae Day right here.